The Hyde approach, the perspectives approach, are attempting to show you how you could derive a particular form of the disorder that we see in the clinic from the bio, psycho, and social realms and bring those things back to life for what is being lost now in our field.
Now, one of the things that comes out of that question, the biopsychosocial question, I'm going to paraphrase several people who asked questions. The idea that research proceeds along particular lines based on what you think or where you might classify the etiology of a particular disorder, that comes out of this approach. For instance, that if you were trying to measure schizophrenia, you'd be looking at genes and neurobiology. Yeah. But if you were trying to talk about extroversion, you might be looking at a very different set of things. If you're talking about alcoholism, you might be looking at a very different set of things. Can you give them an expanded discussion of some of the research topics that you think have gone down the wrong road, like the efforts to neuroimage PTSD?
Right. Yes. And I think the important thing is. All research might be useful. Obviously, you never know what's going to come out of things. But I think a heuristic system should be encouraging people to follow one particular path rather than another. Remember, genes, proteins, neurons, and brains are going to be in everything in psychiatry. It shouldn't be a surprise to you that genes are important in everything, from PTSD and the life story right down to dementia and Alzheimer's disease. What is crucial is to say, in what domain would you find the best understanding of these conditions now, where the things in the biopsychosocial realm would have its most causal power. And we believe that the perspectives is an attempt to show you where this likely power would be. When you produce something that you think is intelligible and send researchers off in some direction, we wouldn't be claiming that what we thought was intelligible is going to be proven by that test. It's going to be challenged by that research test. Just as when we proposed that it was intelligible to think of peptic ulcer as due to an inflammatory disorder of the stomach and small bowel, Marshall and all decided that that didn't seem adequate and challenged that and ultimately proved that, in fact, it was an infectious disorder that was producing the peptic ulcer. Medicine didn't collapse because it had one intelligible conception and it was refuted, but rather advanced. That's the same thing we want to do in psychiatry. We should be having arguments about where these various disorders should be placed. We should have those arguments, but they should be supported by the official classification we have, and that's coming out in DSM-5. And if we don't do that, we're going to be spending more time just fussing around with a field guide.
Well, we're running out of time, but I want to ask one last question. I think it's a really important question. And the slide you showed on CEOs and the impact of losses on them,
right,
and a 20% decrease in productivity for an entire company based on an insult the CEO receives.
Right.
That's telling us something about the role of leadership in fields. And one of the audience members made a good point that leadership in our field could improve our productivity by being more visionary. What do you think's held us back? Why do you think we've been so stuck?
No, that's always a very tough question. I just think we're stuck in a method. We were faced with a problem of diagnostic inconsistency, and a good faith effort was proposed, and that was a very good faith effort, and it came out of the research domain, where the so-called research diagnostic criteria at St. Louis were useful for researchers. They are useful for researchers. The problem was that we decided we were going to use it for everything, all clinical diagnosis. ICD, by the way, has understood the issue of research diagnoses, and now in psychiatry has 2 separate volumes. A volume that permits people to, who are doing research to use particular criteria to identify the disorders for research purposes, in contrast to the clinical volume, which talks about the entity. I think we moved along in this direction appropriately and with a good faith to make sense. And all I'm saying is that happened 30 years ago with the promise that we were going to find, through the research that it permitted by coherent and reliable naming, to be able to move to a more systematic classification. It is 30 years ago. That's a whole generation. Now they're telling us DSM-5 is we just don't know enough, and we've got to just continue with a field guide. And I'm saying, no, not enough. We already have knowledge, implicit, and should be made explicit, that permit us to do better than that.
Yeah, I think that's a great answer. The issue of thinking about diagnostics as a rubric beyond just giving something a name, but telling us something about the nature of the condition,
right,
is very necessary for the work I do, and I'm sure for the work the audience does.
It's what makes psychiatry so interesting.
Yes, and it's what pushes us along. And I think that checking, one of the audience members pointed out that if you have a checklist, you don't need a psychiatrist. And
absolutely,
we are doctors, and we need to be thinking about the patients in more complex ways than an algorithm and a checklist.
Fundamentally, the DSM has taken the contemplative core out of psychiatry. It's the things which psychiatrists, being physicians, can do better than anybody is not only identify cases, but think about them in coherent ways. Without a contemplative core, our field becomes boring.
Right.
But with one, it's the most interesting we've got.
Now, I do want to point out one thing. We both agree, having been there before DSM-3,
right,
that it was a good step.
Oh, yeah.
That we needed it.
It was a good step.
And we needed to discuss
but
these.
That was 30 years ago.
No, I'm with you. I agree. So I don't want people to think that we're condemning that direction.
No.
We needed to develop reliable criteria for some of the conditions we see. We just have developed checklists for everything,
right,
and not everything responds well to a checklist. Anyway, I want to thank everybody for participating in this section. I hope you'll continue to attend our symposium. Dr. McHugh, as always, you've given us a tremendous amount of food for thought, and it is always great to hear you speak about these matters. They enlighten and drive us to do better. Thanks for calling for us to do better. And goodbye, everybody. I'll see you the next hour for the next talk.